Hello, my name is Benjamin, and today we're going to be discussing chronic bronchitis. So, talking about COPD, or chronic obstructive pulmonary disease, we know that it is one of the top causes of death globally and is strongly linked to tobacco smoking, air pollution, occupational dust and chemical exposure, as well as risk factors that disproportionately affect low and middle income countries. Now, with an emphasis of chronic bronchitis, we also know that chronic bronchitis is a form of COPD, which is characterized by persistent inflammation of the bronchial tubes, which leads to a productive cough lasting at least 3 months per year for 2 consecutive years. It is especially prevalent among long-term smokers, but also Okay, all right, so back to where I was. Productive cough lasting at least 3 months per year for 2 consecutive years. It is especially prevalent among long-term smokers, but also affects non-smokers exposed to air pollution or occupational irritants. Starting off with the global burden of respiratory diseases, respiratory diseases are among the leading causes of illness and death worldwide, placing a profound burden on individuals, health systems, and national economies. According to the World Health Organization, hundreds of millions of people live with chronic respiratory conditions and millions die prematurely each year from preventable and treatable lung diseases. Chronic bronchitis has a major impact on individuals by significantly reducing their quality of life. Some signs and symptoms that individuals with chronic bronchitis may encounter are persistent cough and mucus production, shortness of breath, frequent respiratory infections, fatigue and reduced physical capacity, anxiety and depression due to activity limitation. So, in conclusion, respiratory diseases represent a critical global health challenge, affecting vulnerable populations disproportionately. Chronic bronchitis, as a major component of COPD, exemplifies how preventable exposures, especially smoking and air pollution, translate into chronic disability, economic loss, and premature death. Addressing this burden requires coordinated strategies in prevention, early diagnosis, access to essential medicines, as well as strengthened health systems worldwide.
So assessing a patient with chronic bronchitis upon admission. So this type of person might come in to the urgent care ER part of the hospital, coming in with shortness of breath, productive cough, their O2 sats might be low, they're huffing and puffing, trying to breathe. And to start off, mostly we would do a patient assessment on them. We would ask them questions, and we would find out if they have like a smoking history to coincide with the symptoms that they're having, which is, like I said, a cough, expiratory wheezes, productive mucus. Um, Usually in the patient history, they'll have some type of smoking history, and it's probably a long, pack-a-day smoker for 10 years at least, type of smoking history. Um, and yeah, so we would look at breath sounds, we would look at X-rays, we would look at lab values, and just generally the appearance of the patient to see how hard their work of breathing is. Um, to kind of classify where they are in their shortness of breath. So, for common signs and symptoms that we monitor in patients with chronic bronchitis, we are, like I kind of went in, we're going to be listening to breath sounds, and we're trying to have clear breath sounds. Oftentimes, they'll be wheezing, congested. They might sound coarse if they're coming in with a lung infection. Um, and we're looking at their oxygen saturations. We're going to continuously do x-rays on them to see improvement over the course of a few days. We want to see if the treatment is effective, if we have to increase the treatment, or can we start decreasing the treatments and hope that the patient can go home. Making sure the patient is taking their home medications. Usually somebody with a chronic illness like chronic bronchitis, they might not be taking their medications daily anymore. They might start skipping them, and that kind of leads to having issues with a lot of these chronic respiratory patients. Now for treating these type of patients, what we are going to be watching, like I said, is we're looking for the breath sound, or we're looking for breath sounds. We're trying to get a more clear breath sound, or not so rattly breath sound. Therefore, we want to make sure the efficiency of the medications is appropriate. So, like I said before, we would look into maybe higher frequency treatments or lower frequency treatments, but normally they would be short-acting bronchodilators. We usually would use nebulizer treatments. Nebulizer treatments are more effective for a patient that comes in short of breath. Inhalers are something you'd want to prep a patient for to go home, or getting them back to their maintenance. But the two main medication treatments for chronic bronchitis you're going to see is nebulizer treatments with short-acting bronchodilators, and then corticosteroids, so inhaled corticosteroids by way of inhaler. So uh, So, types of airway clearance techniques that we find effective for chronic bronchitis, it would be things like what we call PEP therapy or phlegotherapy. These are little devices that patients can breathe into that kind of make this vibration effect into their lungs, which helps them create a more productive cough to help whatever the mucus that's stuck in their lungs get out so they can start breathing a little bit more clear. And that's how we would assess the effectiveness of the treatment as well. We would be looking at these patients to see, okay, initially they're really, really productive coughs, getting a lot of gunk out, or they're really sick and they're not even able to get anything out, and that's kind of the cause of the issue. So to start getting a productive cough after somebody could not get nothing up is actually a positive sign. And then from that productive cough, we're looking at what the sputum looks like. So for chronic bronchitis, green to yellow tends to be the main colors to show a sign of infection, so some type of lung infection going on, in which case we're hoping that the antibiotics are working and we can start seeing more clear sputum production. Usually after the PEP therapy, we encourage the patient to cough to try to get whatever that we just kind of mixed around up. So that's one way that we measure the effectiveness of the airway clearance devices. So, how do we measure treatment effectiveness and patient outcomes over time for chronic bronchitis patients? So, like any patient with a chronic lung disease, what we're trying to reduce is the amount of hospital visits. They have a chronic condition, and what we really want to do is we want to see those hospital admissions become less and less over time. That'd be a good sign that they're actually, either able to work on their smoking cessation and they've kind of reduced how much they're smoking or stopped altogether. They're able to take their medications daily and they're noticing a huge improvement in their day-to-day life. And they're, their physical activity of daily living gets reduced in terms of effort just by being able to be healthier. Hopefully, over the course of treatments and coming into the hospital and learning about their conditions. One great treatment that we have for treatment program that we have for respiratory patients that suffer from long chronic illnesses is pulmonary rehab. I've always been somebody that encouraged patients to look into pulmonary rehab with their doctors, to get into it, because it really teaches them a lot more on how to manage their condition on a day-to-day, as well as it helps them learn about their medications, the timing of them, the importance of them, and other ways that they can live with their conditions. If they might not be able to live the normal life that they once knew, but they can learn techniques to live as best as possible as they can. So pulmonary rehab is definitely one of those that can help a patient get back to normal daily living without having to see a lot of hospital admissions.
Good afternoon. My name is Angeline Ramos. This is my mother-in-law, Dolly Ramos, and she will be our patient today in regards to our topic of chronic bronchitis. Okay, so can you tell me a little bit about who you are?
Okay, I'm Dolly Ramos. I live in San Jose for over 30 years, and I work in state hospital for 40 years. Then I moved to El Grove since 2019, and now I'm still working in a care home.
Okay, so let's start from the beginning. When did you first notice something wasn't right about breathing?
Oh, I'm having trouble with my breathing and trying to catch up my breath. There are times that I'm trying to grasp my breathing, and most of the time, I have this coughing and progressively continuous coughing.
Okay, so when in that moment that you realized it wasn't just a normal cough?
I feel like I'm not getting enough air, and then gasping of air. So I think it's about time for me to seek for a doctor advice.
That affected the bronchitis? Like, how did, like, outside of your environment, was there anybody around you that was smoking or anything like that?
My husband used to be a smoker, and I'm pretty sure I got it from him.
Oh, okay. So, after that, from realizing it wasn't just a normal cough, when did you go and seek treatment?
First, the doctor thought it was just asthma. Then, eventually, I was kind of referred to the pulmonologist. When I seek the advice of the pulmonologist, they advised me to have a lung function test, which is the spirometer. And then, I went back to my regular doctor, and they said, you have not only asthma, but it's a chronic bronchitis.
Okay. What does shortness of breath feel like in your body?
The shortness of breath is just like I'm having a difficulty of breathing, and then gasping of air, and then suddenly, I feel body weakness, and I feel weak.
So in moments like that, it must be difficult when it's hard to catch your breath. Is there any medication that you use?
The doctor first advised me to take breathing treatment, like like the albuterol, and then like a bronchodilator, so the bronchi will be loosened. Then after that, I kind of breathing normally.
So are you taking any special medications like an inhaler?
Right now, the doctor asked me as needed if I have feeling of difficulty of breathing, wheezing, and sometimes crackles. They asked me to take the albuterol, at least 2 pop.
And then activities. How's your everyday living?
My activity, if I feel like having difficulty of breathing, I know that I have this chronic bronchitis, my activities are very limited. I used to be attending a lot of social activity. Now it's kind of lessened because there's a lot of people. I try to avoid the crowded people because of this polluted air.
So is there anything that triggers your chronic bronchitis?
It will trigger if I have this hard activity that I've been doing before, like dancing continuously. I used to dance 3 to 4 times a week, and then when it started perspiring, after that I will start coughing, and then progressively it will become productive. Then I know I need to have the albuterol with me.
What about seasonal? Is anything with seasonals?
As of today, there's a lot of polluted air. It's so windy. I always protect myself by wearing a mask.
Okay. For your doctors, because I know you go and do your checkups, your annual checkups, and what has your experience been with the doctors with your chronic bronchitis?
Usually, my doctor always listen to my concern and will give me a good advice, which I'm a very good client of him, because whatever advice he gave me, I always do and follow him.
And then, what would you like to say to someone that had just been diagnosed with bronchitis?
I will just say, just don't be negative and listen to the doctor advice and just protect yourself. And as of now, flu season, make sure wear your mask if you are in a crowded place.
And then, what would you say to someone that that isn't really familiar with chronic bronchitis? But what would you like them to know about it?
A chronic bronchitis, usually if you're having coughing and then continuously becoming productive, and if your sputum is kind of thick whitish and then later on it become dark greenish, I will advise them to seek the doctor, because it might be something that he's gonna have, I don't want to say chronic bronchitis or bronchitis, but I will advise them to seek a doctor because of that secretion that she's having.
Okay, thank you so much, Dolly.
Thank you.
Hi, I'm Earl Javier, and this part of our presentation will be discussing why chronic bronchitis can progress to a point where intubation is our last saving option. This initially occurs during AE COPD, your acute exacerbation, and the two factors for this is one, your mixed acidosis, the patient's shift from their condition to mixed acidosis, and secondly, the most common cause is the patient's failure to clear secretions. With that being said, by my side, I have a physician whose expertise is vital to this process. Doctor, if you can kindly introduce yourself and explain your role in regards of intubation and critical care.
I'm Dr. Michael Wong. I'm an anesthesiologist. I work at Mercy General Hospital. As an anesthesiologist, our focus is the ABCs of the patient in the peri-op phase, your airway, breathing, and circulation. But if needed, they can call us for assistance in securing an airway in someone who may have chronic respiratory failure or has a pending respiratory failure, whether in the ICU, in the ED, in different areas of the hospital. And so our job is to kind of come in, secure an airway, kind of help facilitate that. And with the help of wonderful respiratory therapists, that's kind of our ultimate goal.
Cool. So let's let's focus on first division of labor and trust between RTs and anesthesiologists. So in a high stakes intubation, how do you define the division of labor between yourself and the role of the RT?
I think in high stakes emergency situations, that division kind of gets blurred. The ultimate goal, like I said, is to secure an airway, and we all kind of work towards that singular goal. So whether it's me or respiratory therapist or anyone else is securing that airway, then everyone else kind of supports that. You start to think to yourself, what equipment is needed, what backup equipment, what's the next step, how can I help in ultimately getting this goal of getting the airway secured, getting them oxygen, getting them what they need.
So I guess which specific task do you always delegate to an RT versus specifically your task?
If I'm called for an intubation, then I like to keep that task of intubating kind of within my wheelhouse. But ultimately, whether after you intubate, that's not where it ends, right? If intubation by itself is very little, you just have a plastic tube coming out of the patient's trachea. Is everything else that surrounds that's the important part. So getting them oxygen, getting them on a ventilator, getting them what they need, that kind of help is really important. So if I'm intubating, having a colleague I trust, a respiratory therapist who has that work in the background, so as soon as I'm able to intubate, we're able to get him or her on the ventilator, the patient, giving them the oxygen, send those parameters that we think can optimize the patient moving forward.
Cool. So let's kind of pivot on clinical decision making. So can you recall a time or an incident when an RT's assessment fundamentally changed your planned anesthesia or intubation strategy?
Yeah. When we get called for these emergency intubations, we often don't know the patient, their history, their kind of clinical parameters and assessment. Whereas oftentimes an RT does. So in ICU, they may have been working with the patient for months. The patient may have been intubated and failed an extubation trial or accidentally extubated or, had been admitted for respiratory failure and then needs intubation. So oftentimes I turn to a respiratory therapist. They may know what equipment worked last time or what problems that the patient might have. Maybe the patient has subluxed stenosis and they recommend a smaller tube. These are things that when I'm walking into a room, I have no clue.
Gotcha.
So those are really key aspects that I kind of trust.
Got it. So, with that being said, so what is your approach to supervising RTs who's training to perform the intubations themselves?
That's a good question. It's just the all-around preparedness, I guess, of anyone training for intubations. It's the technical aspects of intubating or managing the airway isn't necessarily that difficult, but everything before that, do you have your equipment ready? Do you have backup ready? What's your plan? Does your plan make sense? What is he or she going to do and why are they going to do it? It's very important. If you can't tell me the reasoning why you're doing something, then that's concerning if you're just going through the motion and not really putting behind the kind of knowledge behind it. But if you're able to say all those things and how you react, particularly in a failed intubation or difficult airways, is incredibly important because being able to be still and focused and calm in emergency situations is a skill that shows someone that they're ready to do this in real life.
Yeah, no, that makes sense. So what is the RT's role in your pre-op assessment for a known difficult airway?
Again, their knowledge of the patient, and not only the patient, their knowledge of kind of the environment is very important. Oftentimes they have knowledge of of the patient, their problems, their previous problems, any previous airway or respiratory issues, and then also intimate knowledge of airway equipment, ventilator equipment, if I'm called to some place that I've never been, I don't know where the equipment is. I don't know the ventilator. I may not be familiar with it. And again, intubating is the easy part. Then where is everything else? And having an experienced RT facilitate everything else and making sure that the patient is getting what they need is very crucial.
Awesome. Well, thank you so much. You've definitely highlighted as far as the partnership between RT and anesthesiologists, and not just in the process of intubating a patient, but the overall healthcare and developing a care plan for a patient. So thank you. Thank you for your time, and thank you for your expertise and sharing it for us today.
It's my pleasure.
Thank you so much.
The social and economic impact of chronic bronchitis on individuals is substantial. Things such as healthcare costs, loss of productivity, caregiver burdens, as well as premature mortality are just a few of the things that can affect individuals diagnosed with chronic bronchitis. In low-resource settings, limited access to early diagnosis and treatment worsens outcomes, which reinforces a cycle of poverty and illness. The best way to avoid chronic bronchitis is to prevent chronic bronchitis, as prevention is the most effective strategy, and lung damage due to chronic bronchitis is often irreversible. So plan A would be primary prevention, which would be preventing the disease onset. Things such as tobacco control, air pollution reduction, and occupational safety are the best ways to attack this early onset prevention. A secondary option, or plan B, would be early detection. Early detection of chronic bronchitis slows disease progression and reduces complications. Things such as spirometry screening, symptom awareness, and even vaccinations, which would help reduce exacerbations or hospitalizations, are all things to consider when thinking about early detection of chronic bronchitis. Moving into health policies addressing chronic bronchitis, we have things such as the tobacco and clean air legislation. With national smoke-free laws and environmental protection policies, these would significantly reduce respiratory disease incidence. Things such as universal access to respiratory care, which should include policies that ensure affordable inhaled bronchodilators and corticosteroids, pulmonary rehabilitation programs, oxygen therapy access, and rural healthcare outreach. Low and middle income countries face challenges due to limited spirometry access and medication affordability. And lastly, we could also include integrated chronic disease programs or health system strengthening, which would include training primary care providers in COPD management, telehealth expansion, and standardized clinical guidelines. Strong primary care systems reduce emergency admissions and long-term disability. When it comes to innovations regarding chronic bronchitis, there has been a lot of progression. And with advancements in treating chronic bronchitis, there comes optimism and hope. So here I have a few listed. First one being pharmacological advances. New long-acting bronchodilators and combination inhalers improve symptom control and reduce exacerbations. Pulmonary rehabilitation advancements, things such as structured exercise programs, breathing retraining, and education improve the quality of life and functional capacity of the patient. Digital health and remote monitoring, things such as smart inhalers that track adherence, telemedicine, which enables remote consultations. These technologies improve disease management and reduce hospital visits. And then we also have early risk prediction models. AI and predictive analytics are being used to identify high-risk patients earlier, which allows proactive care. Regenerative and future therapies, things emerging in research such as stem cell therapy, lung tissue regeneration, and antifibrotic agents offers long-term hope, although still largely experimental. So, in conclusion, while there is still no cure for chronic bronchitis or COPD today, the pace of innovation is accelerating. Recent approvals of biologic and novel inhaled therapies mark the first major changes in decades, and cutting-edge diagnostic tools promise earlier, more precise disease detection. Meanwhile, emerging research from AI drug repurposing to regenerative medicine offers real hope that future treatments could go beyond symptom management to fundamentally alter the disease course. Thank you.